The following podcast is part of a certified educational activity titled Revealing New Sequences in CLL, Collaborative Care Planning with Real-World Evidence and Modern Therapeutics. Access the entire activity and complete the post-test at peerview.com/MZC860. Downloadable slides and practice aids are also available.
Hello. Welcome to Revealing New Sequences in CLL. I'm Dr. Jennifer Wyack from The Ohio State University, and I'm pleased to be joined by Dr. Karan Pandya from the UNC Rex Cancer Center. Welcome, Karan.
Thanks for having me, Jen.
Today, we're going to discuss how real-world evidence, new science, and patient preferences are converging to reshape sequential treatment choices in CLL. We'll discuss how academic and community professionals can collaborate when managing patients in the post-covalent BTK inhibitor setting, but also how opportunities for integrating newer strategies may provide more flexibility when selecting upfront treatments. We've collected our practical recommendations on sequencing to be consulted as a practice aid, so you may want to access this resource now. Let's begin. So our goals for today during this presentation, we'll discuss how guidelines for CLL have expanded to include the initial use of time-limited BTK and BCL2 inhibitor-based regimens, as well as earlier use of non-covalent BTK inhibitors. We'll talk about some of the recent science that has reinforced the efficacy of non-covalent BTK inhibitors in the post-covalent BTK inhibitor setting, and supporting this as a role for frontline treatment. We'll talk about patient preferences, treatment goals, and histories, and how safety, efficacy, and logistic factors can inform shared decision-making. And finally, we'll discuss how attention to dosing and toxicity considerations can ensure safe delivery of sequential therapy with targeted agents in CLL. So in Module 1, we'll discuss progress, real-world practice patterns, and persistent challenges in the field. This table shows the regulatory status of our currently available BTK and BCL2 inhibitors in CLL. And you can see that there are some differences between the United States and the EU when looking at what is actually approved in these settings. So in the US, we have the covalent BTK inhibitors, ibrutinib, acalabrutinib, and zanubrutinib all approved. And then the non-covalent BTK inhibitor, pirtobrutinib, approved for relapsed refractory CLL after prior covalent BTK inhibitor therapy. We also have venetoclax approved as an option. In the EU, this is similar, except for ibrutinib is also approved in combination with venetoclax, and acalabrutinib is approved also in combination with venetoclax with or without obinutuzumab, as was studied in the AMPLIFY trial. Pirtobrutinib is also approved for relapsed refractory CLL after a prior covalent BTK inhibitor, and venetoclax similarly is approved. The NCCN guidelines actually provide quite a bit more flexibility in terms of treatment for patients with CLL, both in the frontline and in the relapsed refractory settings. So these are the current guidelines looking at frontline therapy. So we see in patients without 17p deletion or TP53 mutations, venetoclax is recommended in combination with obinutuzumab, and as well in combination with acalabrutinib with or without obinutuzumab. And this can be used either as a fixed duration or an MRD-guided strategy where the acalabrutinib could be continued. As well, covalent BTK inhibitor-based regimens are still recommended, including acalabrutinib with or without obinutuzumab and zanubrutinib. For patients with TP53 abnormalities, we do have relatively the same options, including venetoclax with obinutuzumab, venetoclax specifically with acalabrutinib and obinutuzumab in an MRD-guided manner, and then venetoclax given in combination with zanubrutinib, as well with MRD-guided duration of zanubrutinib. As well, the covalent BTK inhibitors, acalabrutinib with or without obinutuzumab, and zanubrutinib are also preferred in this setting. Looking to second-line treatments, now we have options again for BCL2 inhibitor-based regimens, venetoclax with obinutuzumab. Specifically, although venetoclax plus rituximab is still listed as another recommended regimen, as well as by itself or with ibrutinib. The covalent BTK inhibitors continue to be preferred, and then ibrutinib as another recommended regimen based solely on safety. Here we see the addition of pirtobrutinib given continuously after covalent BTK inhibitor-based therapy. And then thinking about our patients who have progressed after at least 2 lines of therapy, we still have pirtobrutinib as an option, but here we introduce CAR T-cell with liso-cel as another option for therapy in this setting. All right, so with all of these options, we're going to spend some time thinking about how we make these choices, but some of the key principles for starting therapy, and specifically the information that you need prior to thinking about therapy and what to do at progression. Before starting any treatment, it's important to test for TP53 abnormalities, and this should be done before every line of therapy. And this is because we can see clonal evolution and things change during the course of treatment. We also, of course, need to know IGHV mutational status prior to starting your first treatment, but that does not change over time. For patients who start with a BTK inhibitor that's given continuously, if a patient is responding and tolerating therapy, the goal is to continue that BTK inhibitor until progression, or if there is an intolerance that makes therapy have to stop. At progression on a covalent or non-covalent BTK inhibitor, you don't want to have prolonged treatment-free intervals. So the goal would be at the time you think that a therapy switch is needed, you would transition promptly to the next line of therapy. In patients who do progress on a covalent BTK inhibitor, consider testing for mutations in BTK and or PLC gamma 2 to support resistance assessment, and also think about your options for the next line of therapy. These don't and shouldn't be used as routine screening in responding patients, except for in the context of a clinical trial. Curran, how do you think about testing in these situations?
I agree with a lot of what you said. I think at diagnosis, as you alluded to, it's really important to assess IGHV mutation status, and it's important to look at the cytogenetics, and specifically with regards to the either a 17p deletion or a TP53 mutation. And if you are proceeding with continuous BTK inhibitor therapy, I do continue that until there's evidence of either intolerance or progression.
That's great. Thank you. So this is a really interesting study that was published this year. It was an EHR-based real-world assessment of practice patterns, including almost 2,500 patients with CLL, and looking at what people are choosing post-covalent BTK inhibitor. Interestingly here, we see that after a covalent BTK inhibitor, over 40% of the time, the next treatment choice was another covalent BTK inhibitor. I think this is an important point to bring up here because, of course, in this study, we don't know whether the patients discontinued due to progression or due to intolerance. And if in the setting of intolerance, this is a perfectly reasonable thing to do. But I think it's important to remember that all of the resistance mechanisms or the primary resistance mechanism to the covalent inhibitors is all the same. So switching from one covalent inhibitor to another at the time of disease progression is not going to be effective. Here we can see results of a survey that was conducted by PeerView and the CLL Society, looking at over 200 patients with CLL and assessing their views on modern therapy as well as goals and preferences with treatment. On the left here, we see responses to a question about whether patients are getting encouragement and guidance during the course of their therapy. And good news is about 2/3 of them said that they have received consistent encouragement throughout their treatment journey. However, over a quarter of people felt like they received encouragement early on, but this declined over time. So as they were getting additional treatments, the encouragement and guidance seemed to flag a little bit. On the right, we see the response to a question about whether their provider had counseled them on the pros and cons of continuous versus fixed duration strategies. And here we see almost 79% of patients responding that they had heard about both continuous and time-limited options. However, almost 15% of patients had not heard about both continuous and time-limited therapeutic options. Karen, I wonder what you think about this response, and is this typical for what you're seeing in practice?
I think it's interesting. A couple of points I'll make with the graph on the left. I wonder if this is just we have so many upfront line options as far as treatment for CLL, and so there's more confidence among community oncologists in what they're offering and how they're explaining it to their patients. But when there's relapse, maybe there's a little bit more hesitance about where to go next, and perhaps that then plays into how much encouragement they're providing to patients. And then the point I'll make on the survey question to the right, it is a point that I make when I'm discussing treatment with any patient with CLL, to discuss both continuous and time limited options. But I can see that there may be situations in which one option is a much better option for the patient than the other, and perhaps this is why we see that maybe 1 in 5 patients doesn't get as much of a discussion about various treatment options with regards to their CLL.
Yeah, that's a good point. I think you're absolutely right. There are probably some patients, especially, very high risk disease or people that have a hard time getting to and from clinic, that maybe those time limited strategies are not the best option. And then another question that was asked is about prioritization of actors when thinking about next steps in care or next lines of treatment. And the 3 that came out as the most important to patients are side effects and tolerability, long-term effectiveness, and quality of life. Does this surprise you at all, Curran?
No, I think these are kind of what I look at and what I kind of preach to my patients that are receiving treatment actively for their CLL, and that, we talk about this being a disease where there are multiple treatment options available and where the duration of response is rather lengthy. And so we want to make sure that we're addressing quality of life and tolerability. And so this does not surprise me at all.
So the CLL Society actually has a number of resources that can be really helpful for our practicing clinicians when talking to patients about CLL. Here's a listing of a bunch of different resources that are available. Want to note there's a number of support groups that are held, a test before treat biomarker education program, and peer support programs. But please take a look at their website and see whether some of these options might be helpful for your patients. So moving on to module 2, we're going to talk now about building a case for effective care from post-covalent BTK inhibitor to new treatment sequences. And let's start with a case here. So this is Thomas. He is a 74-year-old man who has CLL. He has well-controlled hypertension. He is on anticoagulation for atrial fibrillation. He has unmutated IgHV, but no known TP53 abnormalities. He was initially treated at age 71 with acalabrutinib, responded well to this. However, after a 3-year remission, he now has laboratory confirmed disease progression and is becoming symptomatic. And so, at this point, I think we're going to want to test for 17p deletion and TP53 mutation, like we talked about earlier. Curran, how do you think about this patient and, the treatment history, his preferences, and comorbidities when thinking about your next line of treatment?
Sure. So I think that acalabrutinib is a very reasonable first choice option for this patient. I'll just start with that. And it seems like after about 3 years, it is no longer working. And so I may look at this and kind of gauge, where the patient is at this juncture, kind of symptomatically, as well as looking at their labs and obviously, repeating the 17 TP53 mutation testing as well as assessing for 17p deletions. And this might be a juncture where I actually, reach out to an academic colleague about, are there trials available? I don't, assessing for BTK resistance isn't really part of, my standard of practice, but if there's particular reasons to assess for that, that may be something we pursue after discussion with an academic colleague. And then we'll look at kind of what options are available, some of which we can continue to talk about and kind of discuss at this juncture. Do we want to look at a different covalent BTK? Do we want to look at a non-covalent BTK? Do we want to consider a venetoclax-based regimen, and so on and so forth?
Yeah, I mean, this patient had a relatively short remission duration to frontline acalabrutinib. Certainly, as you mentioned, I think, repeating 17p as well as TP53 mutation is important. I would also test this patient for BTK and PLC gamma 2 mutations, just to kind of understand the mechanism by which they're relapsing and think about how that might affect our next line of therapy. Um, I think I completely agree with you that this is somebody I would really want to think about a clinical trial in, especially with this very short remission duration. If the patient was amenable to it, I would probably choose a venetoclax or obinutuzumab regimen here. Even with the lack of convenience with the obinutuzumab, I think that's something that might have better efficacy right now than the pirtobrutinib. And then, your point about the covalent BTK inhibitors, I think knowing the what kind of mechanism of resistance would be helpful for the non-covalent BTK inhibitors. For example, if there was a gatekeeper mutation, like we sometimes see with acalabrutinib alone, a T474 mutation, there is at least laboratory data that those patients might respond to zanubrutinib. Although, again, my preference probably would be to go out of class in this situation. So, Corinne, I wonder if you might think differently about this case if Thomas had had a 5 or an 8-year remission on acalabrutinib rather than 3 years. He's here to talk about his next line of therapy.
Yeah, I'd say that's a much more durable remission. And so, I think I start looking at options such as the a non-covalent BTK inhibitor at that point, and I am probably thinking more about BTK resistance mechanisms and kind of engaging my academic colleagues in sending testing and potentially further evaluating this.
Yeah, I agree. I feel the same way. I think, in a patient who has a relatively long remission duration on acalabrutinib, it becomes a very easy choice to put them onto pirtobrutinib. It's once a day rather than the twice a day. Usually, if anything, they tolerate it better and probably pretty effective in this setting. So let's look at some of the data that would inform our recommendations here. So first, thinking about pirtobrutinib, so a non-covalent, highly selective inhibitor of BTK. These are some data just from the original phase 1/2 Bruin study, where the median progression-free survival is 18.7 months. Here we get the first hint with the non-covalent BTK inhibitor is that the technical progression does not necessarily equate to the time that a person needs to stop therapy. So median PFS 18.7 months, but median time to next treatment is 23 months. We see this gap even a little wider in the definitive study, but suggesting that patients can very slowly progress on pirtobrutinib for a period of time. So then this is the phase 3 Bruin CLL 321 study that led to the full approval of pirtobrutinib in relapse CLL. Here we're looking at it versus idelalisib plus rituximab or bendamustine rituximab. Median PFS is pretty similar at 14 months. Median time to next treatment, though, is over 2 years, again, suggesting that you can keep people on treatment a little bit after disease progression. Some data that was presented at the ASH meeting this year was looking specifically at second-line pirtobrutinib. And I think, despite the hope that we would see a much longer PFS here, we do still see a median PFS of only 19.5 months, again, a little higher than in the other two studies, primarily because of earlier lines of therapy. Median time to next treatment, though, 32.5 months. And, in addition to pirtobrutinib, we discussed venetoclax-based therapies as an option here. On the left here, we're seeing some data from the Murano study. So this was the study that led to venetoclax plus rituximab being approved for the treatment of relapsed CLL. These patients really were not exposed to prior covalent BTK inhibitors, as most of these were people who were treated with chemoimmunotherapy alone, or some other options here. Median PFS for venetoclax plus rituximab is 54.7 months. Currently, the NCCN guidelines are recommending obinutuzumab instead of rituximab, and that's based on the frontline CLL 13 study, where venetoclax plus obinutuzumab had a improvements in PFS over chemoimmunotherapy, whereas venetoclax plus rituximab did not, suggesting that obinutuzumab is a better combination partner. On the right here, we're seeing data from a study of venetoclax, in this case given as monotherapy in patients who were previously treated with ibrutinib or idelalisib. And you can see venetoclax monotherapy following ibrutinib had a median PFS of a little over 24 months. So we have the expectation that this is going to be better when combined with obinutuzumab. And also this was a very heavily pretreated group of patients where, now if we're using venetoclax-based regimens in the second or third line setting, we expect that the PFS is going to be a little longer than what we see here. And then thinking about venetoclax after non-covalent BTK inhibitors, we don't have a lot of data for this yet. This is a retrospective study looking at venetoclax-based therapies after non-covalent BTK inhibitors with a median progression-free survival of about 23 months. Again, suggesting, like most things, if you use them earlier in lines of therapy, you're going to get longer PFS. Using them a little later is going to give a shorter PFS. And so, these data, and as well, we're going to have emerging data with time, support that venetoclax-based treatments can be used following either a covalent BTK inhibitor or a non-covalent BTK inhibitor. Okay, Karen, let's come back to our case again. So again, this is Thomas on anticoagulation, unmutated IGHV, no TP53 abnormalities. And now, after his frontline acalabrutinib, after about 3.5 years, he continues to have persistent GI toxicity and arthralgias, which are really limiting his ability to stay on this medication. And so what are we going to do about this patient? He says he wants effective therapy, but he's really concerned about experiencing additional toxicity. Would you try to keep Thomas on this treatment? Would you modify the dose, or what would you do at this point?
Sure. I think this is a case I will see every now and then in the clinic. And I think at this point, it's reasonable to just put a pause on therapy while we try to tease out what is it that is bringing on this GI toxicity, and maybe that warrants an evaluation, a formal evaluation with gastroenterology, or some further workup of arthralgias or any side effect that they may be. And I probably take a look at his numbers at this juncture and kind of use that to sort of determine where we are. Is it suitable to take a break, or do we need to push on? And if we do need to push on, then kind of use the patient specific factors to kind of guide whether we shift to a different BTK inhibitor, a different covalent BTK inhibitor, or even consider a non-covalent BTK inhibitor, or even switch to a venetoclax based regimen.
Yeah, I definitely agree. I think your point is really good about stopping the drug first for a period of time and just making sure that your toxicities are actually due to the therapy. I think with acalabrutinib, it is a little bit difficult to dose adjust. If the patient was on zanubrutinib, it gives you a little bit more flexibility in terms of like going down on the dosing, switching to once a day rather than twice a day. And then in this setting too, if somebody has been on for 3.5 years, if they're in a good remission, as you were alluding to, I think it's also a reasonable option to just stop therapy at that point. And then when the disease progresses, then you think about doing another covalent BTK inhibitor or a non-covalent BTK inhibitor or venetoclax. We've seen that in somebody who has had a prolonged time on a covalent BTK inhibitor, they can actually go for even a few years off treatment, and maybe even extending their amount of time that they're going to be able to use that class of drugs. So, what if you did need to switch right away and Thomas had actually discontinued therapy due to very significant bruising or ventricular arrhythmia? Would you switch to another non-covalent, or I'm sorry, another covalent BTK inhibitor in that setting, or would you choose something different?
I think this is a space where I probably look at pirtobrutinib more closely. These seem to be, and correct me if I'm wrong or if this has been different in your practice, but more of a class-wide issue with the covalent BTK inhibitors. And so I'm looking at sort of shifting to a different type of therapy, and I may really look at pirtobrutinib here.
Yeah, I agree. I think, venetoclax would also be a great option in that setting. But really with pirtobrutinib, the amount of bruising seems to be quite a bit less. I think we've seen from accumulated data that severe hemorrhage is pretty similar across all of the BTK inhibitors, but bruising seems to be very different. And then ventricular arrhythmias have not at this point been reported with pirtobrutinib. So I think that's a great strategy. So what's our data for switching between the covalent BTK inhibitors? So this has been looked at with both acalabrutinib and zanubrutinib. And the acalabrutinib study was mostly prior ibrutinib, whereas zanubrutinib had a mix of ibrutinib and acalabrutinib. But we can see that both of these studies showed efficacy in this approach of switching from one covalent BTK inhibitor to another in the setting of intolerance. And with both of these drugs, when prior AEs occurred, they generally were lower grade than what people experienced before. So supporting that you really can make that switch from one covalent BTK inhibitor to another in the setting of intolerance and usually be successful in doing so. And then what about the non-covalent BTK inhibitors? So we do also have some data from the Bruin trial looking at covalent BTK inhibitor intolerant patients switching to pirtobrutinib. And here the median progression-free survival was actually 28.4 months. So in people who were not resistant to a covalent BTK inhibitor, we see a longer duration of remission. It also was very safe. So 3/4 of the patients who had had a prior cardiac adverse event did not have recurrence. And discontinuation due to adverse events was only seen in 5.5% of patients, which is pretty similar to the overall cohort and what we've seen in other pirtobrutinib studies. So supporting that another option would be to switch to a non-covalent BTK inhibitor. Okay, so let's go to another case. So this is Catherine. She is an 83-year-old woman. She has treatment-naive CLL at this point. She does have stage 3 chronic kidney disease. She has atrial fibrillation on anticoagulation, unmutated IGHV, no deletion 17p or TP53 mutations. She has a history of falls and the ECOG performance status of 2. She lives in a rural location, kind of far from her treatment location, and has relatively limited family and caregiver support. Her goals with treatment are to avoid complex therapies, avoid frequent clinic visits, and she really prioritizes safety. So, Corinne, what would you think about in terms of treatment for this patient?
Yeah, so I mean, I think this case is sort of tailor-made for the patient. That it seems that the continuous BTK inhibitor option would be most convenient. I think with any time-limited therapy, we're looking at combined agents, and with the combination comes increased lab checks, sometimes comes an infusion, sometimes comes more visits to the doctor's office. And so I think given that for somebody out more in the rural community, the continuous BTK inhibitors alone are very well tolerated, and after some initial monitoring, don't require a whole lot. I think that the challenge is that they become sort of indefinite treatment options for these patients, and but I think one that's very well tolerated, especially in somebody who already has AFib and is on anticoagulation. You don't have to be as worried about monitoring for that either.
Yeah, certainly the convenience of a continuous BTK inhibitor cannot be beaten. For this specific patient, I would try to tease out and maybe even involve her caregiver if Catherine was willing to discuss with her as well, you know, how challenging would it be to do a few clinic visits to, say ramp up venetoclax, just for the purpose, maybe even considering an acalabrutinib venetoclax option where you could have some time limited treatment. The history of falls concerns me a little bit, especially in somebody who is also on anticoagulation. But completely agree. I think that this patient, usually a continuous BTK inhibitor is going to be what you end up doing. We're going to talk in a minute about some of the data for a non-covalent BTK inhibitor, pirtobrutinib, as frontline therapy. And I don't know if you agree, this is somebody who I'd really also consider the use of pirtobrutinib if available.
Yeah, I think this speaks to sort of the emerging options that are coming into the first line setting for newly diagnosed CLL patients. And so I think we're talking about an option that is arguably as well, if not better, well tolerated, and so maybe very suitable for this patient.
Okay, so let's look at this algorithm a little bit, kind of how we're going to choose between time limited and continuous therapies. And I think, this is the longest discussion that I usually have in clinic is what we're going to do for frontline options. And I think that that's very important though, because all of your later on sequencing really depends on what you choose for your frontline therapy. So, now we have a number of options for time limited treatment as well as the continuous BTK inhibitors. So, kind of some of the pros for time limited treatment, of course, it is time limited. So, the patients are going to have some time off therapy. I think this is especially helpful for younger, fitter patients where, they have a very long lifespan ahead of them, and giving them time when they're not on therapy, I think is both, it's something that they like, but also extends the duration of therapy that you have to offer. There's a lot of logistic challenges with it, but often with some support from family or other caregivers, those can be navigated. And then this really is a good option for people who do have some caregiver support or have the ability to get to and from the treatment center. So in terms of continuous BTK inhibitors, the pros here, obviously it is much more convenient if patients desire like mostly at-home therapy. It's good for people who have difficulty getting to and from clinic visits and those with limited support. I think one special circumstance that we don't know the optimal treatment yet are going to be older and frail patients. We're going to see some data from the CLL 17 study where the frail patient population actually did best with venetoclax obinutuzumab. And of course, like the initial study of venetoclax obinutuzumab in CLL was in patients with comorbidities. So some of these older, more frail patients as well. We're going to also look at some data with pirtobrutinib and the low rates of cardiac toxicity, low rates of discontinuation, even in some of these old or frailer patients. So I think that that's a group that really needs even additional time and thoughts about time limited versus fixed duration regimens. So I mentioned CLL 17. So this was presented at ASH this year and then published simultaneously. This is a really important study, even though we don't use a lot of continuous ibrutinib in the United States anymore. But this is the first trial that's comparing fixed duration to continuous strategies. And so here patients were randomized to ibrutinib alone, venetoclax plus obinutuzumab, or venetoclax plus ibrutinib, where venetoclax obinutuzumab and venetoclax ibrutinib were both time limited at about a year. The primary objective here was looking at non-inferiority of progression-free survival. And we do see that the 3-year PFS is pretty much the same among these 3 regimens, which of course is extremely important. I would argue that we probably need a little bit longer in order to see like any drop off in the patients who were getting the time limited treatments. So these data might look a little bit different at 5+ years, but at 3 years, they are relatively superimposable. So then moving to our emerging option for frontline therapy, and this is the non-covalent BTK inhibitor, pirtobrutinib. As mentioned before, this is a highly selective molecule with a low rate of the adverse events that we generally associate with BTK inhibitors. So there are a couple of recent studies that have paved the way to the use of pirtobrutinib in earlier lines of therapy. One is the Bruin CLL 314 study, and this is a head-to-head trial of pirtobrutinib versus ibrutinib in patients with covalent BTK inhibitor naive CLL. A third of the patients were actually treatment naive in general. The other 2/3 had previous therapy, but no covalent BTK inhibitors. The primary objective here was non-inferiority of overall response rate. We can see that the overall response rate is not only non-inferior to ibrutinib, but actually superior to ibrutinib. Progression-free survival data is relatively immature at this time, but also trends towards favoring pirtobrutinib in the entirety of the patient cohort. And on the right here, we're seeing the treatment-naive cohort where we actually see the most striking differences, both in terms of overall response rate as well as PFS at this time. So at 18 months, 95.3% of patients on pirtobrutinib are alive and free of progression, compared with 87.6% of patients treated with ibrutinib. These are really exciting data. I think the follow-up is going to be really important on this and the next study to really understand what's the duration of remission with pirtobrutinib when given in the frontline setting, because it certainly appears to be better than what we see in relapse CLL. Safety profile, as expected, also favors pirtobrutinib. So atrial fibrillation was seen in only 2.4% of patients treated with pirto, compared to 13.5% treated with ibrutinib. But this was especially pronounced in the population of patients over age 75. Dose reductions much slower with pirtobrutinib. Interestingly, discontinuations were relatively similar between the two, suggesting that you can use ibrutinib more successfully with dose modifications, but overall the safety profile does favor pirtobrutinib. The other frontline study that was recently presented and published is the Bruin CLL 313 study. And this is a head-to-head comparison of pirtobrutinib versus bendamustine rituximab in people specifically with frontline CLL. Here, we're looking at progression-free survival for the primary objective, and relatively short follow-up again, but at 24 months, 93.4% of pirtobrutinib patients remain alive and free of progression, compared to 70.7% of patients treated with BR. So another study showing us that we should not be using bendamustine rituximab in frontline CLL, but here showing that pirtobrutinib is significantly superior. There also was a very impressive difference in overall survival between these two arms. I think the hazard ratio is 0.257 for pirtobrutinib in terms of reduction in the risk of death. Again, longer follow-up I think is going to be really helpful here. Similar to the last study, discontinuation due to adverse events was very low, and the rate of atrial fibrillation was actually, I think, the same between the two arms. So both of these suggest a potential for pirtobrutinib moving into the frontline setting for some patients with CLL. I think, in the absence of a lot of long-term follow-up data, I would reserve it at this point for people who are either older or very frail with a lot of comorbidities, where you think that they might only need 1 to 2 lines of therapy within their lifetime. So let's move now to Module 3, and this is Practical Insights for the Academic Community Partnership. So here's an overview of the CLL management team, and there probably are even additional people that you have in your team that aren't noted here. But here we have the hematologist oncologist, and here we really see a partnership between academic and community practice. We have our pharmacists, extremely important with so many of these newer drugs, oncology nurses who are specifically educating patients and managing adverse events. Corinne, does this look like your practice, or what do you think about this?
In part, I think, we primarily work through an oncology nurse who gives education, and we do consult with pharmacy to provide some expertise on drug interactions. Um, that's usually the extent of our team. And I almost wonder, our practice does not have a cardio-oncologist. Is that something that your group has, and kind of what role does that provider play, especially with the cardiac toxicities that can come with these covalent BTK inhibitors?
Yeah, we do have a cardio oncologist in our practice, and it's been extremely helpful, as you mentioned, as we use more and more of these drugs that do have cardiac toxicities. The cardio oncologist, was actually one of the first to work uh, to quantify the rate of some of these cardiac toxicities with ibrutinib and acalabrutinib. And I think we're, really interested in what's going to happen with pirtobrutinib as well. In general, the way that we incorporate them into our practice is for patients who have known cardiac comorbidities, those who have arrhythmias, coronary artery disease, CHF. We always have them see the cardio-oncologist before they start treatment, help us, evaluate at baseline, and then kind of continue management if there are any cardiac toxicities. I think, of course, as you mentioned, that this is not something that every practice has. And I think something that can be really helpful, in collaboration between community and academic partnerships is many academic centers do have a dedicated cardio-oncologist.
These are the 4 BTK inhibitors listed. Ibrutinib is dosed 400 milligrams once daily. I have a very few number of patients still on ibrutinib, most of which have done beautifully on it for nearing 10 years now. I have many more patients on acalabrutinib, which is dosed 100 milligrams twice daily and is a more selective BTK inhibitor. Zanubrutinib is more selective as well. It's dosed 160 milligrams twice daily, or 300 milligrams once daily. I think you alluded to this earlier in the talk, but the benefit of the zanubrutinib is that we can sometimes get away with 160 milligrams once daily dosing if we do run into some toxicities with it. And then our newest sort of non-covalent BTK inhibitor, pirtobrutinib, is dosed just once daily at 200 milligrams, and it is our most selective BTK. Again, if we look at these class of drugs, we are looking at cardiovascular risk factors, specifically monitoring for blood pressure elevation and increased rates of atrial fibrillation. We are keeping an eye out for hematologic toxicities, namely just cytopenias, bleeding risks, especially if these patients develop AFib or have pre-existing AFib and are already on oral anticoagulants. And then there are increased infectious risks to be closely monitoring for. We do see improved tolerability with the more selective BTK inhibitors as compared to ibrutinib. And a couple other points. Just I think that the hypertension that people can develop with this class of medications is pretty well managed with the use of any antihypertensive medication. Again, you want to be wary of atrial fibrillation and consider bleeding risk and other drug interactions when you're making your choice of the anticoagulation agent. You want to look to see, are they on any kind of antiplatelet therapy? Are they taking NSAIDs for arthritis or other reasons? Arthralgias, we alluded to earlier, can be seen, and a lot of times I will suggest that the patient try Tylenol before going on long-term NSAIDs or certainly anything that is going to further add to the bleeding risk. Interestingly, just with the acalabrutinib, we can run into some headaches that do respond quite well to Tylenol and caffeine, and with the zanubrutinib, we have seen higher rates of neutropenia, where even to the point where GCSF could be considered.
So let's now think a little bit about sequencing. We're going to spend a few minutes kind of going through, I think, some of the more common scenarios that we run across in clinic in terms of patient preferences and how to use our therapies to kind of arrive at these shared goals with the patients. So, one thing we haven't really talked about much is cure or functional cure. Um, for some of our patients, particularly those with very good risk CLL, those who are older, we may be able to treat them with one fixed duration regimen and then have them not require additional CLL therapy within their lifetime, a functional cure. We don't really yet know if we're actually curing any patients with our doublets or triplets, but I think at this point we can safely say that we are functionally curing some of them. So, for those patients who have low risk CLL, who are older, who really say that a functional cure is what they want, or time off treatment is what they want, starting with a venetoclax obinutuzumab or venetoclax plus acalabrutinib is really, really reasonable. At the time of progression, if progression occurs, um, you might consider doing the exact same regimen you did before, or switching the combination partner for venetoclax. If you did venetoclax obinutuzumab, maybe change to venetoclax acalabrutinib. Did venetoclax acalabrutinib, maybe venetoclax obinutuzumab or venetoclax pirtobrutinib. And then for select patients, liso-cel could be used as a potentially curative option in the future. If goal is time off treatment, you're going to think about this in relatively the same way. So a fixed duration regimen, followed by, if necessary, another fixed duration regimen. Think about liso-cel then at that point, or potentially even another fixed duration regimen, again, kind of modifying the combination partners for venetoclax. One thing we see a lot is a goal of decreased visits to the clinic, so convenience. This is especially relevant for people with decreased mobility, people who live very far from the clinic or have difficulties with transportation, have child or elder care responsibilities. And so these are people who will likely want want a continuous BTK inhibitor, either acalabrutinib or zanubrutinib is their frontline option. After progression on this, switching to pirtobrutinib would be very reasonable, and then reserving venetoclax for if you need it. Venetoclax could even be given on its own in patients like this who really don't want to be coming back and forth for the obinutuzumab infusions. And I think as more data emerge from the two Bruin frontline studies we talked about, whether we could substitute pirtobrutinib as the initial therapy here, I think is going to become more clear. We also do know that if we use a non-covalent inhibitor first, you can still switch to venetoclax after. So those patients who might need one or two lines of therapy, you could potentially skip the covalent BTK inhibitor entirely. And what about patients who start with a covalent BTK inhibitor but then discontinue due to toxicity? We talked about the data with switching between the different covalent BTK inhibitors for select toxicities like ventricular arrhythmia, maybe switching to pirtobrutinib or venetoclax in that case. I think the type of toxicity can really help guide your subsequent treatment. And then what about those high risk patients or, patients who just say, I really want whatever is going to give me the longest remission possible. I want to wait for kind of the next big breakthrough in CLL, but do whatever I can to keep a remission now. I think it is the case that the longest remissions that we know of at this time are going to come from the continuous BTK inhibitors. Again, the CLL 17 raised the question of whether that is actually the case, but we don't know at 5 or 10 years. So I think in this scenario, starting with zanubrutinib or acalabrutinib is probably the most reasonable approach. So let's get now to our final conclusions here. So I think what we've seen today is that risk stratification is important. We really do need to be thinking about clinical trial considerations for patients who are interested or appropriate. And seeing an academic CLL doctor in the frontline setting may be helpful for these. If the risk stratification is complicated and could use some additional time and discussion and thinking about that with the patients or thinking about clinical trial options. Our emerging data solidifies the role of fixed duration therapy for frontline CLL. I think this really should be offered as an option for all patients. Many patients don't want this, but just the knowledge that it's available, I think, is important. But for many patients, continuous BTK inhibitor remains a very good standard of care option. And then sequencing options as well continue to expand and include both venetoclax and non-covalent BTK inhibitors after covalent BTK inhibitors, and these can be used alone or potentially in combinations as well. And then soon we may have non-covalent BTK inhibitors as a frontline option. I think we really need to see some longer-term data to best understand which patients are most appropriate for pirtobrutinib in the frontline setting. Curran, can you give us your take-homes?
Yeah, I think from the community oncologist, it's important at diagnosis to assess for IGHV mutation status as well as any TP53 abnormalities. These help in sort of assessing what are the best frontline treatment options. We already have a couple of frontline treatment options of fixed duration, and we have our continuous BTK inhibitors, our covalent BTK inhibitors as sort of a continuous therapy option. Recent data from ASH suggests that there's going to be other combinations and other types of treatment available for our patients. And so I would say that, to sort of finalize my thoughts, it's important at progression, but maybe even at diagnosis, to be discussing these cases with our academic colleagues and referring for any available clinical trials. And then certainly at times of relapse, leaning on them for sort of guidance on pursuing BTK resistance testing, assessing for Richter's transformation and other complications that can come from CLL. And I tell my patients all the time that, it's better to have a few heads than just one. And so it's really important in this day and age that that communication line is open, so we really are making the best decision we can be for our patients.
Thank you so much, Curran, for joining us in this program today.
And thanks so much for having me.
And thank you all for joining us for this program.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, CLL Society. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/MZC860.